Well, in the interest of time, I might as well go ahead and get started.
As I was thinking about what to talk about for grand rounds, I transiently entertained talking about pulmonary hypertension, but as it's such an uncommon disease, I figured it wasn't the most practical topic. And one of the things I really like about the practice of medicine is you really have to keep reading, because paradigms have this tendency to shift on you. And critical care, to me, is one of the greatest examples of that. The stuff that I did as a fellow and a resident was killing people, it turns out. Fortunately, I think I've done a reasonable job of keeping up with the literature and have adjusted to that. We used to keep people down and really maximize their cardiac function and drive up their oxygen levels and stuff. And it turns out we were just torching the lungs and creating all sorts of problems. Another disease that is actually starting to have a paradigm shift happen with regard to the thinking on the disease is COPD. So I figured I would talk about COPD and kind of a general update. And as I was putting it together, I realized it's not the most linear of talks that I've ever given. And so it's sort of a collection of like micro talks and in topics that I think are kind of interesting, but hopefully has some practical applications and I think has some recent thoughts on the diagnosis and treatment of disease. So we'll start off talking about, that's interesting, it converted to interesting symbols at the beginning. Well, so talk about this, some definitions of what is COPD, how do we define it now in 2016, we'll talk a little bit about the epidemiology, and we'll get into this concept of phenotypes within COPD and how those might result from different biotypes or endotypes, and I'll give you some definitions for those terms. And then we'll talk about some of the emerging phenotypes that I find interesting, and then also talk about the GOLD or Global Initiative on Obstructive Lung Disease, the phenotypes that they like and they use to guide therapy. We'll talk about treatments and some of the new treatments that are out there and go into the GOLD recommendations for the treatment of COPD, for medical treatment of stable COPD. I'm not going to spend time on non-medical treatment. It's not a lot of time on invasive treatments of COPD, and I'm not going to spend a lot of time, or not any time, on acute exacerbations of the disease. All this is sort of driven by oncology, so I blame the oncologists. They really want to have personalized medicine, where you sort of look at the specific biology or the biotype of the disease that ultimately is manifested in the individual as a phenotype. In COPD, classically, that's sort of been the distinction between pink puffers and blue bloaters, but you'll see GOLD doesn't really like that notion so much anymore. Biotypes or endotypes are really histological or biological differences within a disease phenotype that sort of denote a unique pathogenic or pathophysiological mechanism that then creates sort of subtle differences within the phenotype, the overarching phenotype. And you'll see some suggested phenotypes in just a little while. So the classic definition of COPD was this chronic bronchitis versus emphysema, and then ultimately persistent asthma was added to that definition, and you might fit in different parts of this Venn diagram. The problem is when they started to look at it, chronic bronchitis is not invariably associated with obstruction. And so it's kind of unusual to have a disease where you define it as obstructive, and then the majority of the people who have this subtype of the disease actually don't have the obstruction. GOLD used to have these stages. GOLD stage 0 was at risk for the disease, that is, you're a smoker, plus you have this chronic productive cough, and they labeled that as COPD. Well, that's a symptomatic diagnosis and not a physiologic diagnosis. And they found those GOLD stage 0 people actually didn't often progress to develop clinically meaningful airflow obstruction, so they dropped GOLD stage 0. Emphysema is a histopathological diagnosis, the loss of alveolar architecture that supports the airways, and is commonly associated with obstruction, but not invariably. About 20% of the people who have radiographic or pathological evidence of emphysema do not have airflow obstruction. Asthma is specifically an airways disease, and persistent asthma is associated with airflow obstruction. But this Venn diagram kind of runs into the problem that a whole lot of the people on this Venn diagram actually don't have the obstruction that is sort of the hallmark of chronic obstructive pulmonary disease. So this group got together and tortured an acronym and came up with the idea that they were GOLD, the Global Initiative on Obstructive Lung Disease, dropping off the inconvenient words like initiative, and used this acronym, and they got together and they created this definition. It is a common and preventable disease characterized by persistent airflow limitation, usually progressive, and is basically a very exuberant response to noxious stimuli. In the United States, the most common of those stimuli, of course, is tobacco smoke. The ATS has a very similar definition. They kind of push tobacco a little bit more because within the U.S., tobacco smoking is the overwhelming risk factor for development of airflow obstruction. Worldwide, that's less true. So you have to get spirometry, which is the test that you use to measure airways function in order to actually make a diagnosis of COPD. Physical examination has a very high specificity for airflow obstruction, but a horrible sensitivity. You can tell from physical exam, 90% of the people who test positive in their exam, 90% of the people who have the disease will test positive in the exam, but a whole bunch of people test positive that don't have COPD. Similarly, in terms of history, that also, mere tobacco smoking is not a good indicator of the development of COPD, because only a minority, as you'll see in a little while, of ever smokers actually develop clinically meaningful airflow obstruction. If you use a cutoff of 70 pack years, which is obviously a fair amount of smoking, that's probably the best historical predictor of the presence of airflow obstruction. You can combine your history and physical, and if someone has no history of smoking and no evidence of wheezing on exam or by history, they're very unlikely to have airways disease. But ultimately, all of this establishes a pretest probability, and your diagnostic test is spirometry. For those of you who are active in the clinics, you'll be glad to know the new PFT equipment is in place. It actually, when you do the PFTs, shortly after the tech does them, it will be uploaded under the media tab into that patient's chart. So if you're in clinic and someone had PFTs last week and someone in pulmonary maybe hasn't read the PFTs yet, not that we would name any names, you can still access them and look at them. And so how would you read them? So the first thing you need to do when you're looking at spirometry is make sure it's a good effort. And the text will say, this was a good effort. It met with ATS standards. Some of the texts are a little better about being accurate in that determination, but you need to make sure it's a good effort. After you've determined whether it's a good effort, you then need to see whether the FEV1 to FVC ratio is below the lower limit of normal. FEV1 is forced expiratory volume in 1 second. Volume per unit time is a measure of flow. FVC is measured in liters. It is a measure of volume. So when you look at the ratio, you're really looking at what is disproportionately impacted. Is flow disproportionately impacted, or are they equally affected, and are both kind of coming down? So you look to see if it's below the lower limit of normal, and if the answer is yes, then they have obstruction of some sort. No matter which way you go, they have obstruction. So what is the lower limit of normal? Who says it's 0.7? Nobody says it's 0.7. Who says that? Yeah, but you're not gold. You're Bob Holliday. Who says it's something else? And what other else might it be? Nobody has any ideas. Fortunately, the BTS, not only do y'all may not have ideas about it, the BTS does not agree with the European Respiratory Society, who does not agree with GOLD, who does not agree with the American Thoracic Society. GOLD uses 0.7, an absolute number, 0.7, in an effort to be simple. Unfortunately, that's also simplistic. In a young, healthy person, a ratio of 0.7 is probably about 60% of predicted. And in an 80-year-old never smoker, it's probably about 100% of predicted. So with young people and old people, the 0.7 really doesn't work out. I use 85% of predicted to determine that. So you get your test, you look at the numbers. If the ratio is low, below 85% or below 0.7 if you like the gold standard. Then you look at their FVC, and if the FVC is okay, then they have obstruction, and you use the FEV1 to quantify that. A lot of people like to say, oh, if the vital capacity is low, that means that they have restriction. The American Thoracic Society does not agree with that. In this, when you come down this pathway where FEV1 and FVC are actually proportionately reduced, and so the ratio is preserved, the ATS points out that half the time these people do not actually have intrinsic restriction. It's related to the fact that they didn't try as hard to breathe during the spirometry. And these people don't necessarily have restriction. They may have gas trapping. That is, their RV intrudes on their vital capacity, and as a result, their vital capacity is below the lower limit of normal. So the focus here really is on obstruction, measuring whether or not someone has COPD. You look to see if the ratio is abnormal, and then quantify how much obstruction, if it's below the limit of normal, by looking at the FEV1. I like pictures. Pictures are simple. There's lots of information in a single picture. Here, the red is the predicted morphology and the relationship between flow and volume. Someone starts breathing, they breathe very hard. They breathe as they get closer and closer to their vital capacity, which is right there, this being total lung capacity. Flow starts to normally fall, and then they breathe back in, hopefully. And this is sort of what hopefully all of us look like in our expiratory flow loop. When someone has obstruction, for any given volume, this being a volume axis, flow is relatively reduced. And the net effect is you get this scooped out morphology. So you can use numbers if you like numbers, or you can use pictures to determine whether or not someone has airflow obstruction. COPD, the epidemiology is widely variable, mostly as a function of what environment you're living and working in. So if you're in the United States, tobacco is clearly the largest risk factor for the development of persistent airflow obstruction. It's notable, in the US, 80% of people who have COPD are ever smokers. It's notable, though, that only about 20% of people, well, we'll talk about the specifics of that, somewhere around 20% of people who smoke will develop clinically meaningful airflow obstruction. There are other risk factors depending on where in the world you are. Environmental exposures, like if you work in mining or grain elevators, those things are not, you're inhaling noxious things and you can have an exuberant inflammatory response. You can have environmental tobacco smoke. You can use biomass fuel sources in your cooking, and your house is all smoky and you're breathing that in throughout the day. So it kind of depends on where you are as to what the actual prevalence of the disease is. When they do population-based surveys, they tend to find that clinically meaningful airflow obstruction, variably defined, is more common and severe than perhaps they expected based on how many people smoked and the like. Like I said, it'll affect somewhere around 5 to 10% of the population in a population-based survey, and it'll vary based on your definition and their tobacco exposure. A very old, not really old, but an older article looked at people who were ever smokers and saw about 10 to 15% had clinically meaningful airflow obstruction, or COPD. Subsequent population-based things would suggest maybe it's 20 to 30% of people who are significant smokers have an FEV1 that's meaningfully down. The airflow obstruction and its health impact actually has significant economic costs. You see in the EU, it costs about 40 billion euros per year, which is getting close to parity now because of Brexit. In the U.S., it's about 40 billion between the direct, about 50 billion between the direct and indirect costs. Most of this is driven by ambulatory care visits and hospitalizations. There are about 17 million clinic visits for COPD, and about 500,000, 750,000 visits to the hospital for COPD. In terms of mortality, right now, or in 1990, it was the 6th leading cause. It's projected to be 3rd or 4th, depending on whose projection you look at, over the next decade or two. Most of this is driven by expansion of tobacco use into developing nations. And it's the only leading cause of death that actually, whose prevalence is actually on the rise. And that a lot of that is driven by the tobacco exposure. So how do we get COPD? GOLD, this is taken from their slide set. GOLD sort of lumps it into two categories. You can develop diseases in the small airways, or you can have loss of parenchyma. And the mechanisms here are slightly different. You see airways inflammation and fibrosis are important. And that inflammation tends to be driven by a cellular immunity that is modified by cytokines. And part of that is also the oxidant injury that happens in the small airways. You can imagine that since there are a bunch of different pathways sort of contributing to this inflammation, that there might be variation between individuals in exact how they get to small airways disease. One person may have overexpression of TNF, while someone else may have too much IL-6. Somebody else might have T cells that invade the small airways in a way that is not seen on the other people. And those might have treatment implications. On the parenchymal destruction, this is emphysema. And here you see this is normal, and this is the emphysematous lung. As you lose alveoli, you lose the attachments that are tethering open the airways. And that's why 80% of the people who have emphysema develop airflow obstruction. But these are pathogenically distinct entities, and you can see how maybe they're not exactly the same endotype, while they might result in a common phenotype, or maybe two phenotypes. So how do people get short of breath? I like this cartoon from Wasserman's cardiopulmonary exercise testing book. Basically, the whole point of breathing in a circulatory system is to get oxygen out to the tissues so that they can metabolize it and create energy and cause muscles to contract. So you see the oxygen comes in from the outside, it goes through the lungs, and then through the systemic circulation and out into the muscles where it's consumed, producing CO2. CO2 reverses that process, goes out to the pulmonary arteries, and is exhaled. You can develop shortness of breath from any point on that throughout that machine that is there. And specifically with regard to COPD, there really are two mechanisms. One is intrinsic to the lung, and the other is related to the heart. As people start to breathe faster, if they've got clinically meaningful airflow obstruction, they can't get the air out, and so they start to gas trap. Their residual volume gets bigger and bigger, which makes it so their tidal volume, their potential tidal volume, starts to shrink. Their inspiratory capacity gets smaller as they breathe faster, and that can make them short of breath, even outside of developing hypoxemia. So if you can imagine trying to run while breathing all the way up at the tippy top of your lungs, it's kind of uncomfortable and doesn't work real well. You can also develop hypoxemia because the alveolar capillary membrane has been destroyed, and as a result, there's not a big enough surface area to actually effectively exchange CO2 for oxygen, and people can desaturate and ultimately not have enough oxygen get to the mitochondria. You can also get cardiac compromise, though. As the lungs get bigger and bigger, they start to mash on the heart, and as they mash on the heart, it can cause impaired left ventricular filling. And then they also, as part of the loss of functioning lung, the pulmonary vascular resistance starts to go up. The lungs are really smart. Their arterioles are trying to send blood to functional alveolar capillary units, and if you've destroyed a lot of those functional alveolar capillary units, those arterioles are going to be clamped down, and as a result, the pulmonary vascular resistance goes up, the RV has to work harder, and cardiac output can be inappropriately or under-responsive to the metabolic needs of the body. And so you can get dyspneic from different possibilities, different pathways, and treatments might vary as a consequence of how you became short of breath. So from these biotypes, these different pathogenic, pathophysiological mechanisms, we might be able to sort of elucidate differences in phenotypes, and those phenotypes may be something that we can approach differently. And ultimately, like all diseases, COPD is a gene-by-environmental interaction, and you might have multiple different pathogenic mechanisms that ultimately result in several larger umbrella phenotypes. And the ones that I want to talk a little bit about, just because I find them interesting or they're evolving, is this asthma-COPD overlap, in which there's a whole lot of interest in the research community, the COPD research community. Sex differences in COPD because it may be that there's a different biology disease, and that may suggest different treatment approaches. And I want to talk about, because I can't get away from it, pulmonary hypertension in COPD a little bit. And then we'll talk about what these are some things that are off on the horizon. Gold has to deal with the current, with the here and now, and as a result, they have their approach, which is a multidimensional approach to sort of categorize people as particular phenotypes based on FEV1 symptoms and exacerbations. And from this, they actually have the very practical application of a suggested approach to treatment. So the asthma COPD phenotype basically is sort of ill-defined, inconsistently defined as fixed airflow obstruction with some suggestion of asthma. And people have implemented this definition variably. Some people say it's if they have bronchial hyperresponsiveness. So if you take someone at baseline, you give them albuterol, and their FEV1 substantially improves, substantial being 200 mLs or 12% and 12%. That person has some reactive airway disease, and that must be related to an asthma component. People have also looked at whether they have eosinophilia, eos being a marker of allergic disease, a history of atopic disease, and some people have actually measured serum IgE and said that is a defining component of an asthma phenotype. When you do that, at least according to this article, when you do that, about 20% of people with COPD will have at least one of these features. And when you kind of look at it as, well, okay, this is really fun and stuff, but does it actually make a clinical difference? If you look across the board, the asthma COPD overlap people tend to have worse intermediate outcomes. They tend to have more admissions. They tend to have more bronchodilator use, greater impairment. But if they're treated appropriately, it may be that actually their mortality is better. When they looked in this study, they actually saw that the people who had 2+ asthma features, so really pretty solid definition of asthma, had a lower 10-year mortality when they were treated with inhaled corticosteroids compared to the people who had no asthma features at all. And so it may be that they have greater morbidity but less mortality, particularly if they're treated appropriately. And there's actually a very recent article that anti-IgE therapy reduced exacerbation frequency and the like in people who had fixed airflow obstruction plus some of these asthma features. So it may be that your treatment's actually kind of varied if you have the asthma COPD overlap. Men and women behave differently when it comes to COPD. Tobacco, women seem more sensitive to tobacco exposure than men. That you see that in the prevalence of COPD, particularly in certain countries. Women have more severe COPD with an earlier age onset and a faster rate of decline, even when you control for the number of pack years and the nature of their exposure. And for those people who have stage fill-in-the-blank COPD, women are more likely to be hospitalized and die within any given year as a consequence of their COPD. When you look at, that's sort of in the macrocosm, when you look down biologically, there actually are different histopathological manifestations in women. Women tend to have much more small airways disease, and it looks more inflammatory, and men tend to have a greater emphysematous component to their COPD. Now, why might these biological differences exist? There are a lot of different thoughts about that. One is that it's anatomic, that if you take women and men of the same height, women's airways on average are relatively smaller. So if you give a puff of tobacco or of cigarette smoke to a woman, there's a smaller surface area across which that is actually being distributed, and as a result, it's effectively a more intense exposure, puff per puff. Also, their FEV1s and FECs tend to be lower, even for the same height, and it may be that they have less room to lose. That is, that they're closer to biologically, clinically meaningful disease than men are, less redundancy in the system. There's also some thought that maybe there are underlying biological differences that also sort of contribute to this anatomic component. There was a recent study looking at a mouse model of COPD where they validated those observations that they've seen in humans, that women had more small airways disease than men, and men tended to have more emphysema than women. But they found that if they did oophorectomy on the mice, that actually the phenotype or the histopathology actually shifted over to the male phenotype, and tamoxifen, in a follow-up model to that, tamoxifen also did the same thing. So blocking estrogen or an absence of estrogen seems to result in different damage to the lung given the same exposure. So when you think about sort of biotypes or endotypes, sex differences may play a significant role in the pathogenesis of the disease and may actually open up treatment opportunities based on those endotypes. So pulmonary hypertension. This pulmonary hypertension as a group, it is WHO group 3. WHO group 3 is pulmonary hypertension related to intrinsic lung disease. There are actually black box warnings on the endothelin receptor antagonist with regard to ILD, saying please don't use these medications without actually consulting one of the pH centers. So please don't use the medications in these people. That said, it is fairly common. I get a lot of referrals for people who have WHO group 3 disease and particularly have pulmonary hypertension associated with their COPD. And when you look by the different stages, you see actually it's pretty common. Gold 2 is relatively mild disease. Nearly 10% of the people will have it. Gold 3 and 4 are more advanced disease, and on the order of a quarter of people will actually have pulmonary artery pressure, mean pulmonary artery pressure greater than 25. So it shouldn't be a surprising phenomenon when you actually do an echo on your COPD patient that they have pulmonary hypertension. On average, it tends to be fairly modest pulmonary hypertension. It's not that severe, but across all the gold groups, you do have about 3% of the people who will have severe pulmonary hypertension. And there's kind of a question as to whether might these people have both disease, both WHO group 1 and WHO group 3 disease, or might it just be that they have so little lung left that all the arterioles are all clamped down. As a result, the vascular resistance is high, and as a result, they've developed severe pulmonary hypertension. And that's often very difficult to wean out or whittle out, as sort out which one is which. The pressures tend to correlate with their PaO2, which kind of would make sense that the more hypoxic you are, the higher your pulmonary vascular resistance would be. That seems to be the case when we send people to the top of Mount Everest. They develop pulmonary hypertension, and the higher they are, the more likely it is that they are going to have an abnormal echo. And it's probably a normal response to hypoxemia. There is some evidence, though, that actually it might be inflammatory driven, and it may not be simply a normal response of the pulmonary vascular bed. In some people, it may be an abnormal response driven by inflammatory markers, particularly like IL-6 and the like. And when they look at the pulmonary vascular bed of people who have pulmonary hypertension related to COPD, the pulmonary vascular bed's not normal. And so there may be something going on here that's impairing cardiac function. And if you have impaired cardiac function and impaired cardiac responsiveness to exercise, you may well have yet another biotype or endotype to target. That this may be something, this group of people may actually respond to therapies, particularly anti-inflammatory therapies, in a different way. Another way by which people can actually have cardiac dysfunction and develop pulmonary hypertension is that hyperinflation that we talked about, that if you get impairment of LV filling, their pulmonary capillary wedge pressure will go up. As their pulmonary capillary wedge pressure goes up, it makes it harder for the right ventricle to push blood into the left ventricle, and as a result, the mean pulmonary artery pressure will get higher. And this is sort of a secondary phenomenon, and instead of targeting, in these people, maybe an anti-inflammatory may not be effective, but really addressing the hyperinflation through their inhaler regimen, or maybe something like lung volume reduction surgery, or maybe other bronchoscopic volume reduction interventions may make a bigger impact than anti-inflammatories. So now we'll sort of switch to, these are sort of ideas that may come up in the next 10 years as this paradigm shift happens from just sort of throwing bronchodilators at everybody under this umbrella of COPD to what are they doing now. And the gold approach to phenotyping, like I said, is multidimensional. And they like to sort of emphasize that it's physiology, symptoms, and exacerbations. You'll see that actually the real emphasis is on their symptoms and on their exacerbation frequency. Ultimately, what they want you to do is locate the patient in a 2x2 table. So it's a two-dimensional, it really predominantly is a two-dimensional sort of thing based on their symptoms and exacerbations. And once you know what group they're in, then the gold criteria people will tell you how you ought to treat them. So the first question you wanted to ask is really sort of quantify/qualify, kind of quantify their symptoms. And gold suggests using these validated questionnaires. One of them is the COPD assessment tool, or CAT. It's an 8-item unidimensional questionnaire. The COPD control questionnaire, or CCQ, 10 items, self-administered and the like. Or there's this dyspnea scores, which is the one I like because it's the easiest one. Is really an NYHA functional class-like thing, where if your functional class, if your MMRC score is 0, you're fine. You're just like everybody else. If your score is 4, then you have breathlessness at rest. If your score is 1 with moderate exercise, 1 is sort of extensive exercise, 2 moderate exercise, 3 is minimal exercise, and 4 is at rest. And so it's easier to remember than all these others. So I kind of take my own approach because you're kind of, you'll see your eyeball estimating it anyway. So I just ask patients, so you coughing a lot? Are you coughing up sputum? Are you short of breath all the time? Are you able to take care of yourself? Do you have to have a handicap license plate, or can you get around Walmart pretty well? Questions like that. How often are you using your inhaler? Some of the asthma questions. And then you can kind of get a gestalt from the person. For the purposes of research, they'd much prefer you to do a much more formal thing. And ultimately, if you take my gestalt kind of view, the more breathlessness, the more impairment in your functional status, the more you cough, all of that kind of stuff, the worse, and the more often you're hospitalized, the worse you are. It seems pretty simple. I like simple. So once you've done that, you're going to put them in one of these 2 columns. So you see, we'll call this column 1 and this column 2. So if you're really doing pretty well, your MMRC is 0 or 1, and you don't have a lot of symptoms and the like, you fit in this column. If you're more impaired and you have a lot of symptoms, then you fit over here. That's your preliminary level in sort of phenotyping for COPD under gold. The next thing you want to do is sort of what they call quantify risk. And risk is about how long-term, how frequent, how much trouble are you going to get in. And in contrast to what your financial advisor will tell you, past performance here is a predictor of future returns. Your exacerbation frequency in the past predicts what you will do going forward, particularly if you do something more than self-report. If you actually look through their medical record and see that on average they are having an exacerbation requiring an urgent care visit or hospitalization at least 2 times a year, the probability is the next year they're going to be seen at least 2 times in the hospital. Self-report gets a little bit softer because there are all sorts of different interpretations of how you're asking the question. If they have steroids at home, which I will do in a frequent exacerbator, they won't necessarily count that. They may underreport, they may overreport. And so you want to put them in either row 1 or row 2 based on a little bit on their airflow limitation. How bad is it? 1 being mild airflow obstruction and 4 being very severe airflow obstruction. Or, as you see, more importantly, on how often are they ending up having an exacerbation leading to a hospitalization. So if someone is showing up 2 times a year, they're up on this top row. And if they've never been hospitalized for anything, they're going to be on this bottom row. So then once you've sort of got them set up in their rows and columns, you see they'll fit either in the A, B, C, or D. And this is a tabular representation of what we just went through. People who are in A have very few symptoms and very few exacerbations. People who are in B have more symptoms at baseline, but it doesn't result in them getting hospitalized very often. Then C are people who have very few symptoms at baseline, but they still get hospitalized fairly often. And on average, those people will have a higher degree of airflow obstruction. And then there's that one square you really don't want to be in, where you have your day-to-day life, you're very impaired, And oh, by the way, you also end up in the hospital fairly commonly. So those are the 4 phenotypes that Gold wants you to put people into. And then from there, you got to implement treatment, because now you've sort of classified them, and you want to then do as targeted a therapy as you can. Gold likes to sort of have people think about, what are your goals of treatment? And they define 2 goals. One is you want to kind of reduce, in the near term, the impact of the symptoms. And then longer term, you want to reduce their risk. That's risk of loss of lung function, because repeated exacerbations result in a higher rate of decline in lung function. And being in the hospital is bad for everybody, and exacerbation frequency can lead to death and disability and everything. I like to remember what the targets for treatment are. It's important to remember that nothing cures COPD. It's not a cure, well, lung transplant maybe, but other than that, nothing really cures COPD. There are some things that improve life expectancy, and we'll talk a little bit about what we know about which ones of those, which treatments fit in that category. There are some things that slow down disease progression, and we'll talk a little bit about those. But virtually all of these interventions that we'll talk about are really designed to make you feel better, whether you measure that by quality of life questionnaires, functional status, 6-minute walk test, your MMRC, or readmission rates. So Gold wants us to think about these 2 target goals. I just think it's important to contextualize that the primary thing that you're going to be able to do is actually hopefully make them feel substantially better. So what are the treatment options? This is kind of a list in no particular order, although I would argue that this is the single most important one that you can do. And we'll talk in more detail about each of these. Smoking cessation. Smoking cessation is a several-day seminar on its own, so I'm not going to spend a ton of time talking about it. A couple of points I would like to make is that one of the things that smoking cessation does is it improves your life expectancy, and it improves the rate of decline of lung function. So this is from Lung Health Study, and these are the people who couldn't quit. And that's the rate of decline in their lung function. Then these are the people who were sustained quitters, which I don't know why that sounds like a negative or pejorative term, when in fact it ought to be a very positive term. These are the people who are able to sustain tobacco abstinence, which is probably happier. And when they were looking at this, they were trying to figure out, so what happens to these people who quit and keep abstinent of tobacco? And in the original publication that they did this statistical method where they did a best fit for the line, but they included this rise, the rise here and the rise, there's a little bit of a rise here when you actually look at the data. And that skews the line into this fairly flat slope. And when you compare that slope to what non-smokers do, it's about the same number of mils per year, 20 to 30 mils per year for a non-smoker, and then the sustained quitters, that's the number that they came up with. So the classic teaching is actually that if you quit smoking, your rate of decline in lung function will approximate that of a never smoker. I don't know that mathematically it was smart to include the bump, because the bump is not a sustained effect. It's not, 5 years from now, you're not going to get another bump offsetting the slope of that line. And when you take this line, it is in between this line and this line. This line's, like I said, about 20, 30 mils a year. This is about 100 mils a year. And this is on the order of somewhere between 40 and 60 mils, kind of depending on which best fit line and which point you choose. And so I tend to tell people that the rate of decline is going to slow down. And I can safely say that no matter which of those slopes that you believe. So getting people to stop, it certainly is a challenge, but the preliminary steps that you can do actually are very easy. Counseling is effective. If you spend 3 minutes saying to somebody, you need to stop smoking, and here's why, and here's how I can kind of help you, about 5 to 10% of those people will stop. And it's a dose response. The more time you spend with them, the more likely it is that they will quit and have a sustained quit rate out to a year. And people have different approaches to how to sort of remember how to best counsel people. One of them is the 5 A's, ask, advise, assess, assist, and arrange. You should ask them, what are your smoking habits? Why are you smoking? What would it take to stop? What are the reasons for stopping? And then advise them, well, here's a good way to stop. You want to stop because you want to be around for your grandkids. Well, when's your grandson's birthday? what a great quit day. Then you need to assess, what is your willingness? Get a sense of how productive this is. And then a system with a plan, with giving them nicotine replacement or other medications, and then follow them up, arrange follow-up to make sure that they're actually continuing down the road that you all have charted in the clinic. So smoking cessation, across the board, single most important intervention you can do in people with COPD. Vaccines, not going to spend any time on vaccines or mucolytics, but the flu and the Pneumovax series it is fairly clear that in COPD they reduce the risk of serious illness and reduce the risk of death if you keep your people properly vaccinated. Mucolytics are one of these older therapies that kind of come and go. If there is an impact, it's small in all the meta-analyses. But one thing that's kind of tempting to look at is the N-acetylcysteine or antioxidant therapy. When they look at people who are frequent exacerbators, potentially a phenotype or endotype, it may be that N-acetylcysteine is actually useful in reducing their exacerbation frequency. If you reduce the exacerbation frequency, you reduce the rate of decline, you improve their morbidity, but you also reduce the rate of decline in lung function, and you also may improve life expectancy. No studies have been powered to sort of show that. The nice thing about Mucomyst, or N-acetylcysteine, it's available at like GNC stores and has limited toxicities other than like GI upset, and then really only with high doses. So I'll use that periodically for someone who has lots and lots of exacerbations. So oxygen therapy, these are graphs from the MRC and the KNOT trial. These people were oxygen 24 hours a day. These people, wait, let me get this right. Yeah, these people were 24 hours a day. These people 12 hours. These people 15. These people no. And you see that clearly in patients who have substantial daytime hypoxemia, the more you wear your oxygen, the less likely you are to die. I think it's notable two things. One, the entry criteria for these studies that showed a positive benefit to it were people with substantial hypoxemia at rest, below 88% or below. And a lot of them actually, particularly in the MRC, they included people with such profound hypoxemia that they also had hypercarbia and right heart failure from their intrinsic lung disease. So these are relatively severe patients and didn't necessarily answer the question of whether people with more modest desaturation would benefit from oxygen. And the other thing that I think is fascinating is when you actually break these down, you notice the survival benefit is not instantaneous. It's not like these curves separate in the first 30 seconds of oxygen. It's not really until 12 to 18 months out that when you look at the individual trials that you actually see a clear separation of the survival curves. So if you see someone in clinic whose SAT is 88%, you don't think it's an acute phenomenon, or 86%, you don't think it's an acute phenomenon, they're doing okay, they don't have to be hospitalized for it. You just have to do the tests that make it so that Medicare will pay for their oxygen, and then write the prescription, and then the oxygen company will deliver it. So what about people with more modest hypoxemia at baseline? This was very recently published in the New England Journal of Medicine. And this study started off with the approach of seeing whether there was a longer time to death in people with stable COPD with moderate resting desaturation, 89 to 93%. So sort of above Medicare criteria, but sometimes we get really tempted. And then they discovered after 7 months and only randomizing 34 people that this was not going to work. They were going to have to change entry criteria, and they're probably going to have to change their outcome. They created a composite outcome, and they included people who on 6-minute walk tests desaturated modestly. And their composite outcome was time to hospitalization, death, and one other element. And you see the survival curves are all about the same. And so they end up concluding, and I think appropriately because the differences between the groups, that in mild or rest hypoxemia, exercise-induced hypoxemia, oxygen doesn't improve survival or risk of hospitalization. It should be noted, though, that oxygen therapy has been shown in these people to improve functional status. So it's not necessarily off the board that these people don't deserve or shouldn't be prescribed oxygen, but the benefits are not going to be the same as we saw here, where there's a clear survival benefit. Other treatments, pulmonary rehab. So what is pulmonary rehab? It's a multi-faceted program that includes exercise training, particularly targeting people who have lung dysfunction. It includes smoking cessation or tobacco abstinence, depending on where they are. It includes nutrition counseling and education about their disease and on the appropriate interventions. Just parenthetically, the nutrition component is kind of interesting because there may be this other unique phenotype or endotype where people have systemic manifestations of the disease, likely through excess systemic inflammation, a higher resting energy expenditure, where they actually have muscle wasting and the like that is independent of the airflow obstruction. So nutrition is an important part of it. Most of the clinical trials that have been done have shown clearly that there is short-term benefit. People feel better, they're less likely to get hospitalized. But these 6 to 12-week programs, their effect only lasts for about a year, year and a half, unless you do something to maintain it. And if you do these sort of over-the-phone prompt kind of things without sort of a more structured follow-up, the effects still will wane over time. This is, again, a relatively recent publication looking at a more formal maintenance program where people came in and they did their core pulmonary rehab program, and then after that period, they started doing this weekly alternating phone call to encourage adherence to the program, and alternating that with a clinic-based follow-up where they would actually have people exercise and titrate the level of exercise that they were doing to any change that they had seen over time. And over time, they end up seeing patients tend to have a better BODE score and 6-minute walk test over sort of the conventional, here's your pulmonary rehab, and we'll call you every now and then to remind you about it. And you see that in this graph. These people, their 6-minute walk tests had fallen off, and these people had a bump. It sort of does slide here later, but this is out to 3 years. And so it may be that getting people more formally or repeatedly in pulmonary rehab is useful. So the inhalers. This is just a busy slide full of all the inhalers, which really can be lumped into 5 categories: the short-acting beta agonist, the long-acting beta agonist, the short-acting antimuscarinics, and the long-acting and inhaled steroids. You notice here that the choice within each class depends on the availability and cost and the patient's response. They really haven't done great trials comparing within each of these one LABA versus another, or one SABA versus another, or one SAMA or one LAMA versus another. The SABAs obviously have a quick onset. Their effect wanes probably faster than the SAMAs. The L-albuterol, which actually I go out to Minden for the chronic vent unit, and people love levoalbuterol. It gets written for all the time, and I cancel it all the time because it's very expensive and really doesn't confer in a general population any additional benefit. So please don't use it. There's this ongoing question about whether high-dose inhaled SABAs and SAMAs, in addition to LABAs and LAMAs, is useful. My understanding at the VA is they really don't like it, particularly in the anticholinergic world. The studies have suggested that high doses of SABA on top of LABA is not real useful. High dose SAMA on top of LAMA as a scheduled sort of thing, or high doses of PRN on top isn't really useful. It may be that lower doses are useful, and you can kind of see, particularly in the anticholinergics, they act at different receptors, and so there's still the possibility that that the addition of a short-acting agent on top of the longer-acting agent confers some benefit. There's a new drug out, Arcapta, that's supposed to be more potent than the others, so there may be some element there. So the inhaled steroids. People are really sort of, because of this, the increased risk of pneumonia, except for in people who clearly have systemic inflammation, as evidenced by repeated exacerbations, people are really trying to move away from inhaled steroids. It's important to note that the only 2 doses that actually have been studied are medium and high dose, and they haven't been compared, so we know nothing about the dose-response relationship for inhaled steroids. We do know that just pulling people off of their inhaled corticosteroids without putting in place another strategy to improve their breathlessness and all that kind of stuff can actually worsen their exacerbation frequency. But if you intervene with another long-acting agent, it may be that you can successfully get them off of the inhaled steroid. Last comment I want to make about bronchodilators, because y'all, I'm sure, know most all of this. One of the things that is very important is making sure they use it right. And there may be some impact in lung function. For some reason, we're moving to dry powdered inhalers. And dry powders and inhalers it requires a certain minimum inspiratory airflow. You got to be able to pull hard of those to get them out, to get the medication out peripherally. And it may be that actually the old-fashioned MDI does a better job, particularly when coupled with a spacer. And in fact, with people with really bad disease, their inspiratory flow is so cruddy that even the MDI with a spacer may not work as well as a nebulizer. Inhaled corticosteroids are available by nebulizer, and the short-acting meds are also available. So you really ought to, in clinic, you encourage your patients to bring their inhalers with them, look at how they use them, and get a sense of how hard are they able to pull at it. And if they're noticing that it feels like it's all in their mouth and they have severe COPD, you might change to an MDI because they may have a better response to that. And if it's really bad, you might just switch them over to nebs and see if that does any good. One more tirade. The phosphodiesterase inhibitors, roflumilast, is relatively new to the market, and you'll see it's prominently featured in the GOLD recommendations. But I tend to believe, and there's an article titled this, is roflumilast merely expensive theophylline? And I tend to believe that actually the answer is yes. They have not gone head-to-head, though. You see their mechanism of action is very similar. It blocks phosphodiesterase, inhibits phosphodiesterase 4. It's a little bit more selective, but ultimately it increases CAMP in the cells. Both of them have some anti-inflammatory effects, and both of them can have bronchodilators. Clinically, they're very similar effects, may improve respiratory function, may improve FEV1, may improve FEV1, reduces exacerbation frequency. And these people who are relatively frequent exacerbators, they saw about a 15 to 20% reduction in exacerbation frequency. And in contrast, in theophylline, in a meta-analysis, they saw a 50% reduction in exacerbation frequency. And there are real cost differences. Low dose, medium dose theophylline, $30 a month, $360 a year. Roflumilast, $220 a month if you're lucky, for the roughly $3,000 a year. So you can go, maybe 10 years on your theo before you paid off your roflumilast. So I'm clearly not a big advocate for roflumilast. I'd try theo first, and if the response is inadequate, then I would go over to roflumilast and see if it made a difference. So Macrolides is another. This is a not quite ready for prime time intervention. They took people who had COPD with exacerbations, put them on 250 milligrams of azithromycin a day, and noticed a reduction in exacerbation frequency. There's also concerns, though, out of this that you increase the resistance to macrolides, which are very useful in treating COPD exacerbations. My own practice is if I have somebody who has relatively frequent exacerbations, I give them short courses of prednisone and azithromycin, give them a prescription to have at home with refills. That way they don't have to come to the ER and sit, if they start to get sick at 10 o'clock on a Saturday night, they don't have to come and sit there and watch all the traumas go through while they're short of breath. They can intervene at home, because really that's what we do in the hospital. We give them steroids and antibiotics. That allows them to intervene. If they don't improve, then they can come to the hospital. And if they're going through it enough, they're effectively ultimately they sort of put themselves on chronic azithromycin therapy. So putting it all together, the way the GOLD people want us to. Remember, we have our 4 categories, really not much going on. These people have symptoms but aren't ending up in the hospital. These people don't really have a lot of symptoms, but they go to the hospital, and these people just are in a tough place because they have both symptoms and end up in the hospital. So GOLD group A, these are the people, non-pharmacologic therapy. Everybody should stop smoking. Stop smoking. Everybody should exercise. Exercise. And depending on where they are, what the CDC says, make sure you get their vaccines. If people have disease that arguably is clinically manifest, then they need to stop smoking, and you need to think about pulmonary rehab. Plus, they need to exercise and get their flu shot and a pneumonia vaccine, or Flumivax. Should be all in one shot. So these are the official gold recommendations. In Group A, just use PRN medications, much like mild intermittent asthmatics. They have alternative choices, including theophylline or long-acting agents. I would argue if you're going to this, you're probably not in Group A. You probably actually have persistent symptoms, and maybe you're more appropriately over in B. After that, you see with these people that have lots of symptoms, but not so much showing up in the hospital, starting off just with a long-acting muscarinic antagonist or LABA is pretty reasonable. And most people would start off with a LAMA because there's some suggestion it may do a better job of reducing exacerbations and has better data to support the idea that it reduces risk of mortality. And you can add in other things later. You can do combos if you have an inadequate response. And you see they stick theophylline way over here. For people who have more systemic inflammation, that top row with their exacerbations, they include inhaled steroids, which I think is fairly reasonable. Starting off with a combo of inhaled steroid and LABA, maybe a LAMA because it does also reduce exacerbation frequency. But the first line was probably an inhaled steroid slash LABA, but no one would criticize you choosing between those. If you don't get a good response to that, you can start adding things in, so-called triple therapy, inhaled steroid, LABA, LAMA. And then you can start thinking about other things. You notice they put their PDE4 inhibitor here, even though they've kicked theophylline off into the other possibilities. I would put it over in this column and put the PDE4 inhibitor over there. And then if you're really sort of sick, you really probably ought to do at least triple therapy plus think about adding in some of these other things and start thinking about anti-inflammatory things like N-acetylcysteine and or theophylline. So that's all I have to say about COPD and sort of where we are now and sort of what are some things that may modify treatment interventions down the road. So keep an eye on it. It's an evolving science, and it's certainly changed from when I was a fellow. When I was a fellow, there was a guy, Joel B. Karlinski at the VA, and he said that he'd been a pulmonary physician for 30 years and nothing had changed. And I think that we're on the brink of substantial change. He was right back then because all we had was adrenergics, anticholinergics, and steroids, and we're thinking about how we use those differently, and we're starting to add some new medications. Sir. Oh, Lord.
You mentioned briefly about the asthma COPD overlap. So the slide before that, when you talk about mechanism, would you do something different in those people? Would you start with inhaled corticosteroid earlier on, or how would you do that?
Yes. There was that one population study that looked at the people who had two asthma elements and persistent airflow obstruction, and their mortality was lower if they actually treated them with inhaled steroids. So I think it's steroids in that. That's much more clearly an inflammatory disease, and so I think steroids have a much better validated role in those. It makes biological sense, and there's some literature to support it. All right.